Today, I shall talk to you about sepsis, and the main objectives in this lecture for you would be to know the sepsis definitions, what infections produce sepsis, what's the pathophysiology, how to diagnose sepsis, how to treat it, and some other issues as well. Okay. Sepsis, in brief, it is two things: infection and inflammation. Infection and inflammation. It's the clinical syndrome where we would have end organ damage because of a dysregulated inflammatory response to infection. So what we have here is the infection that is resulting in an inflammation that goes dysregulated or exaggerated, if you want, which will result in the end organ damage. So this is it basically, and let's see how. Now this is the 2016 definition. It's a life-threatening organ dysfunction caused by a dysregulated host response to infection. And I mention here SIRS, S-I-R-S. Now SIRS is the systemic inflammatory response syndrome. The systemic inflammatory response syndrome. I know that the voice is ما بعرف شو عم يعمل. شو رأيكم؟ ماشي الحال؟ طيب. Okay. Systemic inflammatory response syndrome. I put it here because in the past it was put as a separate entity and it was tied to infection. Now the definition is as you see in the middle of this slide, just as you see it there, without mentioning the systemic inflammatory response syndrome. I will come back to this, which will make it clearer to you. Now the criteria for the systemic inflammatory response syndrome are mentioned here, and they are from up to date. If you look at this slide, it's very simple. This is when the temperature is high, above 38, or abnormally low, below 36. So temperature above 38, below 36. The heart rate is increased more than 90. Respiratory rate is also increased more than 20, or it can also be reflected by washing out the CO2, so the partial pressure of arterial CO2 would be lower than 32. Those are like equivalent. And the white blood cell count can be high or low. So those simple parameters, which we can test for either by examining the patient or doing the basic tests for the patient, we can appreciate these things. And I shall clarify further. Now, epidemiologically, how important is sepsis? It's actually very important because, as you may think, that we have infections commonly, and infections, if they are severe, they will result in an exaggerated immune response, which would result in the end organ damage. Now, sepsis is increasing slowly with time. Why? Because of advancing age of the population, immunosuppression, multi-drug resistant microbes and infection, also the detection of early sepsis from aggressive sepsis education and awareness campaign. Like I am talking to you today about sepsis, at every level, almost every year, as Med 2, Med 3, 4, there would be talks to you to remind you of sepsis. And in practicing medicine, especially in the emergency setting, you would look for the diagnosis of sepsis. Is the patient septic or not? Which will have certain consequences for the workup and management of the patient. Now, in the United States, sepsis is most commonly found in the African American males. Okay, and the most common infection that results in sepsis usually, generally, including in the ICU, are respiratory infections. Now, importance of aging. We know that the population is aging with time, in the sense that longevity is slightly increasing decade after decade, and hence they are the group that are more susceptible to sepsis. Infection and bacteremia. Infection is defined as the invasion of normally sterile tissue by organisms, resulting in infectious pathology. Bacteremia is the presence of viable bacteria in the bloodstream. So you see the word bacteremia mainly reflects the bacteria in the bloodstream, bacteremia. Another word is like fungemia, where you would have the fungus in the bloodstream. Viremia is also mentioned. We don't measure that in clinical medicine regularly or routinely, but a patient who would have a viral infection and would be chilling, shaking a little bit, then we say that the patient probably is viremic, or the viremic stage of the viral infection. In HIV, for example, the human immunodeficiency virus, we measure the viral load, we measure the viremia to define the case and treat the patient. Okay. Now, important infections. What are the infections that produce sepsis, or they may produce sepsis? On the top of this list, you see here, well, the light is too strong in here. It should be dimmer. If anybody can know how to dim it, that will be better. You can see the slides better then. But pneumonia. Pneumonia is very important. Yes, thank you very much. Pneumonia is very important, a very important cause of sepsis. It is not as common as urinary tract infection. Okay, urinary tract infections are quite common, whether in males or much more commonly in females, especially the older males and females. So urinary tract infection is very common. But usually it does not result in sepsis, except in certain situations when it is severe. Pyelonephritis, when the upper part of the urinary tract is involved with infection, the kidney, that's where the urinary tract starts. So tissue infection of the kidney, denoted by pyelonephritis, is very important to produce sepsis. Or infection of the urinary tract with obstruction. A lot of people would have stones formed in the urinary tract. So if a stone forms in the kidney and then it moves down into the ureter, it may obstruct the ureter. If there is infection, you would have infection plus obstruction, and the system on one side usually will act like an abscess, producing the microbe will multiply and increase, and it will produce the chemicals that are produced by the microbes, the bacteria, which will trigger sepsis, like we shall see in a short while. But going back to pneumonia, please remember that it's a lung tissue infection. It's an infection of the lung, the tissue of the lung. And this is very different from the upper respiratory tract infection. Nowadays, we live in the days of corona. Okay? Corona is one of the respiratory viruses. And we have got so many respiratory viruses. We tell patients or people that the influenza vaccine would protect us against influenza. But it will not protect us from developing the regular common cold or grippe, because there are about 100 viruses, mostly rhinoviruses, adenoviruses, any kind, including there are 4 coronaviruses which are well known, and they can produce a common cold syndrome. But you may know already that the important thing about the new corona, okay, the novel corona, the SARS-CoV-2, is that the S protein on the surface of the virus has got receptors in the alveolar cells, in the lungs inside. So it goes into the respiratory system, but it can home onto the alveolar cells in the lungs. That's why it can produce a pneumonia. This is when the lung becomes involved. Now, in the case of bacteria, the bacterial infection usually in the lungs may produce the pneumonia and sepsis. Cholecystitis and cholangitis. Cholecystitis is infection of the gallbladder. something that is fairly common and that we should look for. We would have a patient with fever in the hospital, and we cannot find the infection easily, like a pneumonia, a urinary infection. You examine the abdomen and it is fine. You look for other causes of infection and you don't find it. But then we should always think of the gallbladder and we should search for the infection. With time you will learn that infection on the gallbladder is not easy to find and diagnose. You have got to search for it. But cholecystitis, if it is hidden and we are not treating that and we are not operating on the gallbladder, may result in sepsis. Cholecystitis refers to infection of the gallbladder itself. But what if the bile ducts are obstructed with secondary infection? That is called cholangitis, obstruction of the bile ducts with infection. Abdominal infections, I will not talk to you about meningitis, endocarditis, septic arthritis, and soft tissue infection. All of these can produce sepsis. So we have got many infections. Now, pneumonia tops the list because usually it produces a serious infection. This is one thing. And second is that in the ICUs, in intensive care units, in the intensive care unit, pneumonias are more common because the patient would need more respiratory care, so they are more common, and hence pneumonias come to top the list for cause of sepsis, especially in ICU patients. Okay, this is from the up-to-date, and you can see there more examples of infections that are detailed further. You can see it on the slide, or if you open up-to-date, you can see it there. Now the pathogens, I will explain to you later that it can be any kind of bacteria, gram-positives, staph and strep and other species, or gram-negatives. Okay, now the gram-negatives I write here, especially here in the Middle East. In the United States, they have got more commonly than we have MRSA, methicillin-resistant Staph aureus. So let's say if young people are playing sports in the field and they get injury with infection resulting from that, they would always think of MRSA. It's fairly common in the United States. Whereas in Europe and in the Middle East, staphylococci become less frequent. They are there. Of course, they produce wound infection, but more commonly we encounter gram-negatives like E. coli, Klebsiella, and others. So both are important, gram-positives and gram-negatives. Fungal sepsis is becoming more important with advanced medicine in the immunosuppressed. And there is the entity in approximately half of cases of sepsis, an organism is not identified. Hence, you may refer to it as the culture-negative sepsis, but still, if you think, how can I diagnose sepsis and I don't have an organism, we shall see the criteria to diagnose. Okay, risk factors for sepsis, bacteremia, the presence of bacteria in the bloodstream, advanced age, immunosuppression, diabetes, cancer, pneumonia, we said, intensive care unit admission, prior hospitalization, and genetic factors, of course. Now, is the intensive care unit admission a criterion for sepsis? Actually, it simply suggests to us that the patient is in need of a lot of medical care, and sepsis becomes more common in this patient group. Prior hospitalization, if the patient was in the hospital the month before, then it may reflect to us that the patient may be harboring some nosocomial microbes or flora or pathogens. That's why. Symptoms and signs. How can we find the effects of sepsis? Arterial hypotension, a low blood pressure, a mean of blood pressure below 65 or systolic below 90. So the patient would be hypotensive, low blood pressure. Temperature, like we saw with SIRS before, more than 38.3 here it's put, and less than 36. The heart rate, tachycardia, and tachypnea or a rapid respiratory rate. If you think of those, they are very simple. Starting from the lower tachypnea here, if the patient is breathing more rapidly. So we have got to be careful in looking at the patient, in examining the patient, if the respiratory rate is rapid. Very important. The heart rate also, whenever we come to measure that, the temperature. Okay, so those are the main signs of sepsis which we find. Organ dysfunction, it will affect any organ. Respiratory, hematology, that is the blood count, platelet count may drop, the white BC count may be high or low, as we said, the liver, bilirubin and liver enzymes, renal, creatinine and urine output, the brain, you can measure the consciousness of the patient by the Glasgow Coma Score or scale, and cardiovascular hypotension and need for vasopressors. Okay. Some further signs is that the skin, when you come to examine the patient, would be initially warm. The patient is fairly well perfused, but when the blood pressure drops further, the body has got to protect itself and protect the major organs. So blood is diverted from the superficial skin into the important internal organs, the brain, the heart, the kidneys, the liver. So the skin will become cold with peripheral vasoconstriction. Decreased capillary refill, cyanosis or mottling may indicate shock, and the mental status of the patient or the consciousness would be affected. Like you see here on this slide, now, yes, I'll take your question in a minute. What you see in the skin is that there is here what we call as mottling of the skin, mottled skin. You see, it's like islands, white islands surrounded by reddish discoloration of the skin. This is called mottling. It reflects hypoperfusion. However, this mottling you may find in normal people, otherwise normal people, without infection, without fever. So that's, it's called livido reticularis then, and it's not that important. One more finding in the skin. You see here such lesions if the patient is febrile, if the patient is unconscious like you see on the right hand side in this lady, a patch of redness, a white patch of redness on the face with a central necrotic lesion. This may go with sepsis very well. And those lesions in the lower panel in here we have got something like pustules actually, a little bit of pus under the skin with a reddish or dark spot on top. This may reflect septic embolization, a tiny clot which carries bacteria which may embolize to the superficial skin. Yes, please. Faddal. Hypotensive with blood constriction. Of course, let me say that with the progression of infection, if the patient is not treated adequately, first the patient would have fever. With the fever there would be vasodilatation, and the skin, as I said, may be warm initially. But if this state persists and the patient does not receive treatment by staying longer at home before coming to medical attention, the blood pressure will start to drop, low blood pressure, and there will be automatically autoregulation with vasoconstriction. Of course there will, but that vasoconstriction is not enough. And as you will see, part of the inflammation is that there will be capillary leak. So the fluid will leak out from the capillaries, from the blood to the interstitial space. Hence the volume of blood will be decreased. And hence, one of the major treatments for sepsis is IV hydration, intravenous hydration, like we shall see. Okay. Now this mentions again the different organs that are affected, and you can go through it. Don't worry about the numbers specifically, but they will give you examples in here. So, in sepsis, we have the inflammatory responses to sepsis or infection and the procoagulant responses in sepsis countered by anti-inflammation and anticoagulation. So we have got inflammation with coagulation plus trying to balance it in the body by anti-inflammation and anticoagulation. Now in this, the bacterial toxins are very important to trigger the immune response. Now cytokines, which are secreted by our own cells, inflammatory cells, they will mediate the process of inflammation, and the most important one in those is interleukin-1, as you see here. So you see septic patients will have like a combination of the systemic inflammation, coagulation, and impaired fibrinolysis as well. Okay, here we see on this slide an example about infection producing leading into sepsis. And what we see first, the lysis of gram-negative bacteria. So we are starting here with the gram-negative infection. The lipopolysaccharide is released from the outer membrane of gram-negative bacteria. It comes to be taken up or bound by a lipopolysaccharide binding protein, which takes it to the macrophage. Here we have the macrophage. And the macrophage is the main or the initial, the first and the central cell in inflammation. So the macrophage is activated by this lipopolysaccharide with the help of other ligands around the receptor here. So induction of transcription and activation of the macrophage to produce the cytokines. As I mentioned, the most important one is interleukin-1, but we have other interleukins, tumor necrosis factor, platelet activating factor, which result eventually in coagulation, prostaglandins, leukotrienes produced with further inflammation, activation of the complement. This will result in the damage of the blood vessel endothelium and capillary leak, as well as damage of the organs wherever they are affected, with the multi-organ system failure as well. Also, we can have acute respiratory distress syndrome in the lung and DIC, disseminated intravascular coagulation. So this is the example of the lipopolysaccharide producing sepsis. Biologic effects of pro-inflammatory cytokines, the interleukin-1 and tumor necrosis factor. Here we see it again: fever, hypotension, acute phase protein response, induction of other cytokines, coagulation activation, fibrinolytic activation, leukocytosis, and other factors, including increased endothelial permeability, okay, and other metabolic effects as well. All right, so sepsis is mainly concerned about dysregulation of the inflammatory, anti-inflammatory, coagulation, anticoagulation responses of the body. So we come back to the bacteria that are producing this infection. In the bacterial cell wall components, we have endotoxin that I shall show to you in the next slide, peptidoglycan, muramyl dipeptide, and lipoteichoic acid. Those are components of the cell wall which may produce sepsis. Bacterial products like staphylococcal enterotoxin B, toxic shock syndrome toxin, and other toxins which may induce sepsis. Here, if we look at the cell wall types of gram-positive versus gram-negative bacteria. If we start with the gram-negative bacteria, you see here in the middle of the slide, we have got a component of the outer membrane here that is the lipopolysaccharide. So as the bacteria are multiplying and reproducing, they will release lipopolysaccharide, and also the immune system will be fighting them and killing those bacteria. So the lipopolysaccharide is produced more by the immunity and inflammation, and when we come to treat the patient as well, we'll be killing more bacteria and release of lipopolysaccharide. Hence, this lipopolysaccharide can trigger sepsis as well. In the case of the gram-positive bacteria, we have the teichoic acid moiety, which was studied more than other cell wall component, and it can also trigger the immune system, inflammation, and result in sepsis as well. So sepsis can occur whether with the gram-negative bacteria or gram-positive bacteria. And this is in the gram-negative, just to show you, here we have the outer membrane, and we have got the endotoxin or the lipopolysaccharide, and in here we have got a periplasmic space between the outer membrane of gram-negative bacteria and the inner membrane. Okay, and this is magnified from the wall of the gram-negative bacteria. So there, we have got the component of the cell wall which can result in sepsis. Septic shock. Septic shock, this is when the blood pressure goes down and it is profound blood pressure and not picking up by simple measures, especially whenever we are giving the fluids. You would come to give 1 liter, 2, 3, 4 liters of fluid, and still the blood pressure, the systolic blood pressure is below 90 or below 100. This is when you would think of septic shock. And this is actually reflected by measuring the lactate usually, lactic acid. Why? Because the cells will be metabolizing mostly anaerobically. There is no good blood pressure to bring over the blood and the RBCs carrying the oxygen to the cells to metabolize aerobically. Hence, the cell will start to metabolize anaerobically and produce more lactate, more lactic acid, which we can measure. And one of the criteria of septic shock actually is the lactate here. Okay, so this is with the hypotension. And in septic shock, there can be a higher mortality up to 40 or 50%. Lactic acid, elevated serum lactate, more than 2 correlates with sepsis, and more than 4 correlates with septic shock. Yes, please. That is right. The difference between sepsis and septic shock can be, like you see on this slide here, by the measurement of the lactate, which reflects the cell injury, let's say, during the process of septic shock. But septic shock, the term shock, reflects low blood pressure. And when we say septic shock, it means that the patient has got the infection with a low blood pressure, and this low blood pressure is not responding to fluid supplementation. Hence, we have got to go to further modes of treatment like the vasopressors directly, okay, to try to elevate the blood pressure. So we have got sepsis and the severe septic shock, which is a type of vasodilatory or distributive shock. Okay. And the capillary leak syndrome becomes important as well, with increased endothelial permeability. Now, the complications of sepsis can be many, and here you can see, according to the different organs, in the lungs, adult respiratory distress syndrome, disseminated intravascular coagulation. What this term means is that the coagulation process will be activated. Okay, platelet activating factor secreted and induced by the cytokine. Those platelets which are activated will come to clump on each other and produce tiny clots. And this occurs within the blood vessels. Hence the term disseminated, general, intravascular coagulation within the blood vessels. Now this will be counteracted by anticoagulation so that the blood vessels will not be clogged or obstructed. And this results in the process of DIC, where the coagulation factors will be consumed with time. We have coagulation, anticoagulation, and hence the end result is that the patient will be subject to bleeding because they don't have enough of coagulation factors to prevent bleeding, let's say from injured mucosa or from a peptic ulcer or whatever. So DIC is a process that results eventually in bleeding. Central nervous system dysfunction, renal failure, intestinal bleed, heart failure, liver failure, those may result in death, of course. Now, mortality in sepsis. Sepsis is most important in critically ill patient. If you have a patient in the emergency room and the patient is very sick with hypotension, you would give fluids, 3 or 4 liters of fluids. You would start on the vasopressors, but such a patient would have to be put in the intensive care unit under continuous monitoring and under continuous nursing care with medical care as well. So that's why a patient who is put in the intensive care unit, يعني مش خطر the intensive care unit itself, but rather this patient is in need of a lot of medical intervention, which carries with it also a lot of risks as well. So that's why. So sepsis is most important in the intensive care units, and as I said, that pneumonia is one of the most common infections there and causes of sepsis, and the mortality of sepsis generally is about 33%. So septic patients have a mortality around 33%. And when you come to do studies, you have to have two arms in the study, measure the mortality in your septic patients, and then compare this mortality to the mortality after a specific intervention, see if you can improve on that or not. Okay, but generally the mortality of sepsis is about a third, 33%. In the case of septic shock, it will go higher to 40, 50% like you saw in the previous slide. Okay, the sequential sepsis-related organ failure assessment score. Okay, what we have here actually is a method about how to suspect sepsis, how to come to manage the patient. Here we have got the Q-SOFA, the SOFA score, which is the sequential organ failure assessment score, and the Q for the quick SOFA. So you take three parameters, which are the respiratory rate, if it is high, above 22, altered mentation of the patient, very simple. You talk to the patient, if the patient responds or not, and you can have some criteria if you want to measure it carefully by the Glasgow coma scale, and then a systolic or blood pressure less than 100. This is a rapid assessment of the patient. If two points of these or the 3 points are positive, then there is a high risk of sepsis. Now, why do we have to identify sepsis by name? Because the management of sepsis usually comes in a bundle all together, like we shall see. Now, non-infectious mimics of sepsis, other major diagnoses, can result in the same process, like hypotension or inflammation or bleeding, like acute myocardial infarction, acute pulmonary embolus, acute pancreatitis, massive fat emboli syndrome after fractures of the long bones, acute adrenal insufficiency, gastrointestinal hemorrhage, overzealous diuresis and hypotension or dehydration, transfusion reactions. You see, there are many entities that will result in diagnoses similar to sepsis but without infection. Important blood tests to take, like you see here, the white blood cell count, which can be high or low. Blood differential, which means that the white BC count will have percentages of it. A higher proportion of neutrophils goes with bacterial infection and sepsis. The fibrin degradation products as well for DIC. Blood gases can be measured and would reveal acidosis. You measure the oxygen tension, the carbon dioxide tension, and the pH, which is normally 7.4, as you know, and acidosis whenever it drops down. Procalcitonin can be measured, and it's one of the gauges of sepsis as well. And the CRP, the C-reactive protein, which is a common acute phase reactance that we measure with infection. So there are different parameters that we can take. Blood cultures are very important. We have got to secure a sample of blood in culture bottles, and this should be done prior to the initiation of antimicrobial therapy. Because if you give your antibiotic, you will be inhibiting and killing the bacteria, which may or may not grow in your blood culture bottles later on. So whenever you think of infection, bacteremia, and sepsis, we have got to take blood cultures. Management of sepsis and septic shock in adults. This comes usually in resuscitation bundles. So whenever you would have a septic patient or we suspect sepsis in a patient in the emergency unit on presentation, we have to activate a bundle of management, like stabilize the respiration, which means provide oxygen, give some respiratory support by whatever mechanical means. You know, you may know that we have got the BiPAP system, which is a non-invasive respiratory support we can provide it to the patient other than giving a higher tension of oxygen per se. Assess and restore perfusion by giving fluids, intravenous fluids. Vasopressors if the blood pressure is not picking up. Appropriate antibiotic therapy, of course, after taking the cultures, so we have got to secure them rapidly and give the antibiotic, and definitely ask for intensive care for the patient. And then we have got to think of the accurate diagnosis of the infection to control the septic focus by surgery or drainage or removing an obstruction from the urinary tract or from the biliary tract or wherever it is. Vasoactive agent in septic shock, this is again from up to date, but the main vasoactive agent that we use is norepinephrine, like you see here. And norepinephrine has got the common effect on the heart rate and contractility, of course, both the heart rate and the contractility, positive effect, and the arterial constriction also to elevate the blood pressure. So it's mainly norepinephrine. Of course, epinephrine would have its specific uses. Dobutamine would have its specific uses in the cardiac patient, but the others are less commonly used. Appropriate antibiotic therapy. Now, I put this slide just to stress to you that thinking of the diagnosis and the likely organisms is very important, because the antibiotic therapy would have a better outcome if it is appropriate antibiotic therapy. And if you hit the organism with your initial antibiotic therapy from the beginning, then the outcome of sepsis will be better. So it is important for us to make sure whether we are dealing with a urinary infection versus a respiratory infection. In the lungs, gram-positive cocci become more important. Streptococcus pneumoniae, Staphylococcus, they are more commonly encountered in the lungs than gram-negative bacteria. Whereas in the urinary tract, it's mainly the gram-negatives like E. coli, which everybody mentions and knows, your patients mention it to you, Klebsiella pneumoniae, Proteus, so the treatment. And then, if you think that the patient may have nosocomial infection, if the patient was in the hospital the prior month or 2 months, would have to target higher organisms, more resistant organisms. So that's why whenever we come to work on the patient who has got sepsis, as the bundle is going on for the diagnosis and for the management, until the chest x-ray comes out, we secure the blood cultures, we think of the likely diagnosis, we go back to the chart of the patient, look up the cultures that they may have had before, and target organisms that we see in the cultures, plus whatever we suspect to be producing the active infection. So appropriate antibiotic treatment is really important, and it contributes to a better outcome. So in the management of sepsis, as written here, the optimal management includes mainly early goal-directed therapy, the EGDT, lung protective ventilation, antibiotics, and additional therapies, including the careful use of corticosteroids. So you see here, corticosteroids comes in the end. If the patient is not responding to the basic managements, which starts with the fluid supplementation, then vasopressors, and the blood pressure remains low, so we have got to go to other modalities, more modalities, including corticosteroids. So steroids may come in the end of treatment, yani later in the management of sepsis, rather than in the beginning. And this resuscitation bundle is really important. Here we have got a study, although it is 2012, but this is an important study by a reference in sepsis management, Dr. Emmanuel Rivers, and he was Dr. Gilbert Abu Dagher of our emergency department was working with him, and they have got this study. Let's see, they wrote that the resuscitation bundle consists of early diagnosis, risk stratification using lactate levels, hemodynamic response after a fluid challenge or fluid supplementation, vasopressors, antibiotics, source control, and hemodynamic optimization. This is referred to as the EGDT, early goal-directed therapy. And again, to explain it to you further, if you think of the EGDT, it's early, good, goal-directed. So you identify your low blood pressure as an important point to work on. So this is one of our goals, to improve the blood pressure. So in the early goal-directed treatment of hypotension would be fluids. Later on come vasopressors, and later may come the corticosteroids. If the oxygen is low, then you would have to supplement oxygen first, and then you would have to support the respiration of the patient by the BiPAP, positive airway pressure breathing for the patient. And if this does not succeed, you may have to intubate the patient, put a tube into the lungs, and put the patient on mechanical ventilation, especially if they are not really conscious and they cannot breathe well. Keep their airway open and breathe well. So this is mainly the early goal-directed therapy. I can tell you also a story about that, especially that we are finishing early, is that around the year 2000, which is already 20 years ago, there were several studies about sepsis, actually 4 studies which were published in the best journals, the New England Journal of Medicine and the Lancet, American and British. And those 4 studies, one of them was about the use of corticosteroids. And in that study, they said that corticosteroids, if used early, they can be helpful. Another study about strict sugar control, because in older persons, whether they are diabetic or not, there will be dysglycemia. Metabolic control of sugar will be lost, so they would tend to have hyperglycemia. So controlling the sugar strictly in this group of patients. Third, there was also activated protein C. Activated protein C contributes to the inflammation and coagulation. And it was found to be depleted, activated protein C. So there was a study about supplementing activated protein C, and the 4th study was about the early goal-directed therapy, which means to identify the abnormal components and address them in the management. Actually, all of those studies, the 3 studies, except the EGDT, were nullified. They were not reproduced over years, although we kept on following them for years after years. But eventually, what has remained is mainly the early goal-directed therapy. So we have got to define our goals, our targets in management, and work on them. And this is when intensive care becomes important, starting with the emergency unit. The blood pressure is low, so you'd monitor it and you would measure it every 10 to 15 minutes. If it remains low, you give more fluids. Then when you come to the vasopressors, you start with your vasopressors at a low titration or a low concentration and follow up the patient every 10-15 minutes and go up in increments. Why? Because the vasopressors will produce vasoconstriction. So there is a price that we are paying for our treatment as well. And we don't want peripheral vasoconstrictions to the extreme, especially in the susceptible patient with atherosclerotic disease. So this is mainly, so it's a matter of time. Whenever you suspect a septic patient in the ER, you would have to work rapidly for the diagnosis and for the cultures and the escalating management. Questions, please. Yes. Yes, excellent question. I can put it, the question is, how do we wait for the blood cultures? Or actually, it's mainly what's the usefulness of blood cultures, especially that they would take time to come back. And the time that we give for blood cultures, we don't expect results before 24 hours, even if we suspect the patient is bacteremic. The organisms, the bacteria in the blood culture will take time to grow. at least 24 hours, sometimes a bit shorter, but also we give time up to 3 days. The first 3 days are the most important for a blood culture. The decision to treat infection and sepsis is a clinical decision to start with. And you look for different parameters to suggest to you what is the kind of infection that we are treating. If you take the simple urinalysis, for example, analyzing the urine, finding white blood cells in the urine reflects to us that there can be a urinary tract infection. Also, if you take other parameters like the leukocyte esterase and the nitrite in the urine, again they reflect the presence of bacteria there. So that will suggest to you possibility of UTI. If you do a chest x-ray and you see infiltrates on the chest or one segment or one lobe that is opacified, it tells you that the patient may have a pneumonia. So taking the cultures will be very good initially. And this will help us decide on further antibiotic treatment. So initially, you would have to give broad spectrum antibiotics usually. And this is the current practice. And most of our antibiotics nowadays are broad spectrum antibiotics. But if you get the organism 2 or 3 days later, it will be very helpful for de-escalation of the antibiotic and the practicing antimicrobial stewardship. Instead of continuing with the broad spectrum antibiotic, you would go for more specific antibiotics then, more targeted treatment, which will have less side effects, of course. So the importance of the culture, I cannot tell you more how important it is in further management of the antibiotic treatment. If we have a positive blood culture, we consider that we are lucky, the patient is lucky, that we have a specific target to treat with antibiotics. This is very, very important. If we don't have cultures, then I would say that not that we are lost, but we have got to go along with the broad spectrum antibiotics that we have started with. Other questions, please? Yes. Excuse me, علي صوتك شوي. Yes. Okay, the question is about the management of the sugar control. Sugar control. Of course, in a patient with hyperglycemia, we should treat the high glucose. We give insulin. Hydration also will help the high glucose very much. Simple hydration will bring down the glucose level, but also, of course, insulin and some other treatments that may be used. But what I meant about that study is the strict sugar control. Yani if you decide to bring it below 150 or 140 or 130, this becomes a strict sugar control, and it was found out in those patients that hypoglycemia becomes more common, and hypoglycemia can be detrimental to the patient. So this is what I mean by the strict sugar control. Of course, we should practice sugar control, but not strictly. Yani bring down the glucose, bring it down from 400 or 300 down to 200, 150. This would be an acceptable range. 180 will be very good as well. Yes. A cause of non-bacteremic sepsis. Of course, a very important question. Whenever you would have a localized infection in the body, but without finding the bacteria in the bloodstream. So, no bacteria in the bloodstream that we can catch, at least with our cultures, although if we do more blood cultures, maybe we can find it. But to us, the absence of the bacteria in the bloodstream means that there is no bacteremia, but still the patient may have a very intense or inflamed infection, like the pneumonia, or like cholecystitis, as we said, or an obstructed urinary tract with severe infection. So it can be, and the presence of such infections are very, very serious. Let me tell you that recently, before the epidemic of corona, we had a patient about 1.5 months ago, and she was a 62-year-old lady taking also Humira and anti-TNF treatment, immunosuppressive therapy for Crohn's disease, the inflammation in the ileum and colon. And that patient developed some respiratory symptoms. Her family suspected that she would have a viral infection, and after being in a family gathering in the Gulf area, she came back to Beirut just to spare the younger kids from getting the infection as well. But then the patient remained at home for a couple days. She had fluctuating fever, taking Panadol, responding to the Panadol, but then on Monday morning, the husband would be calling and saying that we could control the fever, doctor, but my wife has got rapid breathing, tachypnea. You see, she was breathing rapidly even at rest. So that's a very abnormal finding. And this is the example of tachypnea and septic patient. And me and others, of course, we told him immediately, you have got to come to the emergency room. And that patient, we found on the chest x-ray that she had complete opacification of the right lower lobe of the lung. Such a massive pneumonia that we don't see every day. It's a rare finding, a really massive pneumonia. So that patient was septic, and by the afternoon, she was intubated, actually. And eventually, we could not save her. We gave her a lot of antibiotics, not only the broad spectrum antibiotics. We gave her 3 or 4 antibiotics because we did not have positive cultures, but we had other parameters to indicate the type of the infection. But still, it was a sad case and we could not save her. So without bacteremia, of course, the patient can be septic with a severe infection. Not necessarily always. If the infection is small or limited and the immune system can deal with it in a regulated way, then there need not be sepsis at all. It starts with an infection. It starts with bacterial infection or fungal infection in the immunocompromised. Viruses would rarely produce sepsis. They don't usually produce sepsis. Other questions, please? Okay. Protect yourself from corona. Thank you.